Hello, I'm Dr. Sheela Chakravarthy. In continuation of our series of anemia for Go Campus, let's understand megaloblastic anemia. Megaloblastic anemia is anemia caused by vitamin B12 deficiency. And vitamin B12 is basically available in animal food rather than vegetarian food, but it's available in milk and milk products. So vegetarians who take milk and milk products can manage from not having a manifested megaloblastic anemia. Normally, the requirement of vitamin B12 is just 1 to 2 micrograms per day, which is available in regular vegetarian diet. But people who use a vegan diet, who do not take animal and animal products, are more prone for megaloblastic anemia. Just to understand a little trivia about vitamin B12, in patients who were anemic and iron therapy was given, some of these patients did not improve after taking iron therapy. That's when the patients who had protein manifestations of neuropsychiatric involvement, patient had anemia, did not improve with iron therapy, then the name pernicious came because we are not able to really understand what was happening to these patients. It was then that few of the scientists like George, Richards, Minot, and William decided to give liver to patients who had developed no improvement with iron therapy, and they found a remarkable improvement in the patient's general condition. But some of these people, even after taking liver therapy, did not improve. Then a person by name Castle decided to eat meat and then aspirate his gastric fluid and give it to patients who had not improved with just liver therapy. All these the patient found a remarkable improvement, and that's how the diagnosis of the intrinsic factor came into existence. All these were self-motivated doctors who developed Nobel Prize for their achievements. The natural source of vitamin B12 is basically animal products, basically meat and egg. It's also found in milk and milk products. The source of vitamin B12 in vegetarians are basically milk and milk products. It is also seen in some of the harmless bacteria found on green leafy vegetables, because we use a lot of water to wash off the pesticides on the green leafy vegetables. These harmless bacteria get destroyed, and we do not have a natural source of vitamin B12 in vegetarians. So where does absorption happen for vitamin B12? Absorption could be passive or active. That means patients who have got, when we give very supranormal or more than 1000 microgram doses of sublingual, oral or buccal vitamin B12, 1 to 2 micrograms can be absorbed from the buccal mucosa, which makes it possible for patients who do not eat, who are megaloblastic anemia and cannot tolerate meat diet, can be managed with supra high doses of vitamin B12 orally. The mechanism is that when we give supranormal high doses, 1 to 2 micrograms is a normal requirement of B12, which is adequate to prevent the development of significant megaloblastic anemia. So once all of us have to understand that how is B12 absorbed. So as I told you, it is a passive absorption is when you give supranormal doses, but most of the active absorption happens through the digestive tract. So one eats food, the saliva and the gastric secretions isolate the vitamin B12 from the food, and it gets attached to a protein, transcobalamin protein called as heptacorin. So B12 gets combined to heptacorin, and that is not destroyed by the acid in the stomach and reaches the intestines. The pancreatic juice trypsin takes away the heptacorin from the B12 and gets it attached to the intrinsic factor. So the intrinsic factor with B12 goes directly to the ileum, where you have cubilin receptors, which binds to the internalize the intrinsic factor plus vitamin B12 into the ileal thing. Our intrinsic factor gets released and vitamin B12 is released into the circulation. In the circulation, it gets transported as with transcobalamin 1, and it enters the systemic circulation as transcobalamin 2 receptors. So one can explain problems with vitamin B12 deficiency when you have a problem with release of intrinsic factor which happens in the stomach, failure of release of trypsin, or in the ileocecal area where any infections in that area can be responsible for manifestation of vitamin B12 deficiency. So one can identify what may be the most likely reasons why a person can develop megaloblastic anemia. So what is the function of this vitamin B12? There are two active forms of vitamin B12. One is methylcobalamin and the other one is adenosylcobalamin. The methylcobalamin is basically responsible for giving the methyl transfer to the reaction where homocysteine is converted into methionine, and this reaction also needs folic acid. That means when you have homocysteine to methionine, this methionine is required for neurotransmitter production. So that can explain why you can get neuropsychiatric manifestations of vitamin B12, and is also responsible for the methionine is required. So when a person has got methylcobalamin deficiency, there is increased production of homocysteine because the homocysteine gets converted into methionine by the methyl transfer given by the methylcobalamin, which is available as methicobal, and the folic acid, which also helps the methyl transfer. The second part where cobalamin is adenosylcobalamin dependent enzyme. This acts again for a methyl transfer for a methyl malonyl coenzyme A to succinyl coenzyme A, which is required for DNA synthesis and also required for myelin production. So you can understand when there's a deficiency of methylcobalamin, two areas can be involved. Patient can develop deficiency of B12 can cause anemia. Deficiency of B12 can impair the myelin synthesis. So your symptoms will be basically around these areas. So dietary causes of vitamin B12 deficiency in India, one should know. In India, there is a lack of balanced diet. There is very little availability of fresh vegetables and very less availability of, not all of them are meat eaters. The proportion of cereals to vegetables is usually 4:1. That is, a large amount of calories comes by cereals rather than protein. For growing people, pregnant, as we discussed in iron deficiency anemia, pregnant, lactating mothers, adolescents, all need very high levels of vitamin B12 to match up to the growth. And so because of the lack of availability of these in a vegetarian diet, most of them manifest as vitamin B12 deficiency anemia. So gastric causes, then we go back to the causes of vitamin B12 deficiency. Since we know that the intrinsic factor is produced from the stomach, any condition that causes atrophy of the stomach, or there is a gastric bypass, or there is a gastrectomy, then the surface that is required for the production of intrinsic factor gets compromised and they can develop vitamin B12 deficiency anemia. The most important part of vitamin B12 one should know is pernicious anemia, which is basically because of development of autoantibodies against the intrinsic factor, which is produced by the parietal cells in the gastric lining. When people have pernicious anemia, they also have autoantibodies against the thyroid. They can develop vitiligo. They can have Addison's disease. It's a part of a multi-endocrine antibody production. The most important cause of vitamin B12 deficiency is also H. pylori infection, because H. pylori also competes with B12. So when a person undergoes gastric bypass surgery, one has to expect that the person can develop B12 deficiency. Basically, these people have to be managed in the post-operative period or a little later with B12 supplements. Intestinal causes of B12 absorption. As you know, the final binding of intrinsic factor plus B12 happens with the cubilin receptors in the ileum, and we know that in India we have very high risk of ileocecal tuberculosis, which is one of the most important cause of megaloblastic anemia. The second, enteric fever, which involves the ileal region, the Crohn's disease, which involves the ileal region. So any of these can be responsible for the development of vitamin B12 anemia. When you look at upper GI, as I also wanted to include celiac sprue-like and iron deficiency anemia may be responsible for vitamin B12 also. And since we know that trypsin is produced by the pancreas, so pancreatitis can also be one of the reasons for development of vitamin B12 deficiency. So since we know that trihydrofolate gets converted into tetrahydrofolate, any reductase, dihydrofolate reductase inhibitors like methotrexate also can cause vitamin B12 deficiency. Among the drugs that are commonly used are metformin and proton pump inhibitors. Both of them prevent the absorption of vitamin B12. So one has to commonly expect or anticipate megaloblastic anemia in diabetes, maybe because of the usage of metformin. In the West, there is a very high availability of B12, but most of the Westerners are getting into a vegan diet. So the expectancy of B12 deficiency in the West is seen in this group of people. So once you have understood about B12 deficiency, you can imagine what are the common clinical manifestations of vitamin B12. When you look at hematological manifestations, since it impacts the DNA synthesis, the maturity of the RBCs happen by reduction in the size of the RBCs. Since there is an improper DNA synthesis, the RBCs remain big. So the mean corpuscular volume is very high as compared to iron deficiency anemia, where the mean corpuscular volume is low. And they are one of the reasons when there is a refractory iron deficiency anemia, there is a pancytopenia, one has to always suspect B12 deficiency. Normally, bone marrow is not required for identifying B12 deficiency, but it comes as a differential diagnosis for pancytopenia, which is treatable and completely curable if the patient takes proper supplementation of B12. Bone marrow in vitamin B12 deficiency is usually indicated only when the patients don't respond to treatment. Most common presentation of vitamin B12 deficiency is just not anemia, that is not megaloblastic anemia, macrocytic anemia, but there is also pancytopenia. The neutrophils are usually multilobed, that is very characteristic of megaloblastic anemia, and there's also drop in the platelets. So any condition which comes with anemia with macrocytosis, raised LDH, has WBCs, particularly neutrophils which are multilobed, and thrombocytopenia, one can keep vitamin B12 as a probable high degree of suspicion. Since it mainly involves the rapidly multiplying cells, so the clinical symptoms are basically glossitis. You can also look for knuckle pigmentation, and most of the manifestations are related to anemia like tiredness, fatigability, breathlessness, or heart failure. The neuropsychiatric manifestations can be explained by the homocysteine not getting converted to methionine. Methionine is a precursor for neurotransmitters of the brain. That's one of the reasons. The second reason is the myelin synthesis gets compromised because of the methylmalonyl not getting converted into succinyl coenzyme A. Both these are responsible for the neuropsychiatric manifestations of megaloblastic anemia comes in the differential diagnosis of Alzheimer's disease because it's a reversible and a correctable cause of the disease. The neurological manifestations basically, since it involves the myelin, the most of the thickest myelin are found in the proprioceptive receptors, the sensory tracts. And since as all of us know that non-myelinated thin fibers are the pain and temperature, which do not get impacted, but the sensory fibers where the myelin sheets are very thick are basically involved. So the presentation of a posterior column involvement is called as a subacute combined degeneration of the cord. It basically involves a posterolateral column, manifesting basically with a severe sensory ataxia. In pregnancy, it is one of the reasons for hyperemesis gravidarum, and this complication of vitamin B12 and folic acid, as all of you know, can cause neural tube defects are known. So all pregnant women have to receive supplementation of folic acid to prevent the development of neural tube defects during pregnancy. The most worrisome serious complications apart from heart failure and cardiovascular is the development of thrombosis. Thrombosis is predisposed by high levels of homocysteine, and this is one of the most common cause of cortical venous thrombosis, more common in women, and it comes as one of the differential diagnoses of identifying vitamin B12 deficiency. Should be ruled out all patients who come with cerebral vascular accidents secondary to cortical vein thrombosis. It can also cause peripheral thromboembolism, pulmonary thromboembolism. The premature hair changes, the presence of graying of hair. One of the reasons have been implicated is vitamin B12 deficiency. So once you have identified, what will you expect in clinical examination? So patient will be pale, patient may have pigmentation, black pigmentation over the knuckles. The patient may have premature graying of the hair and signs of anemia. So when you look for clinical findings, what should you look for? Clinical findings, we ask for a blood count. The CBC will show hemoglobin will be low, but MCV will be very high, more than 100 FL will be. That's the diagnostic criteria for diagnosing vitamin B12 deficiency. The WBC will show leukopenia, but they will be multi-lobed granulocytes. Platelets will be low or normal. Bone marrow need not be done for all patients of vitamin B12 deficiency. Patients can have jaundice or splenomegaly or unconjugated hyperbilirubinemia and increased LDH, all which are seen in hemolysis. The cause for increased LDH is the premature RBCs, because they are not matured, they get destroyed, and there is hemolysis. So there is hemolytic anemia and megaloblastic anemia come as one of the differential diagnoses. So once you have made a diagnosis of a probable pernicious anemia, one has to do test to find out whether it is a vitamin B12 deficiency. So we can check for the vitamin B12s. Normal vitamin B12s are between 160 to 800 in different labs, but it is the test labs are not very conclusive of low vitamin B12 deficiency. So vitamin B12 deficiency alone, without any megaloblastic picture or neuropsychiatric manifestations, cannot be concluded as megaloblastic anemia. If all features of vitamin B12 deficiencies along with low vitamin B12 is there, one can conclude the patient may have a pernicious anemia. Since pernicious anemia and megaloblastic anemia are different, we can also ask for anti-intrinsic factor antibodies, anti-parietal cell antibodies, as to confirm whether it is a pernicious anemia. So once you have identified that the patient is having vitamin B12, we have to manage the treatment. So treatment is if the patient cannot has anti-intrinsic factor antibodies or anti-parietal cell antibodies, or has a gastric bypass surgery or a gastrectomy, ideally the patients cannot absorb vitamin B12. Most of the time the patient has to be on intramuscular replenishment of vitamin B12. So how do we treat? We give 1000 micrograms either daily for 5 days or alternate days for 5 days or weekly once for 5 days, following it with 1000 micrograms or 500 micrograms per month for life. But if the patient has got a condition where he does not have, example, if metformin is the cause for B12 deficiency, we can supplement some vitamin, supranormal doses of vitamin B12, so that the patient deficiency does not become manifest, because it's not possible to stop metformin in diabetics. Is one of the standard line of treatment. So one has to have a high degree of suspicion in patients with vitamin B12 deficiency, because it is one of the differential diagnoses of lymphoproliferative leukemia, myelodysplastic syndrome, but it is a completely treatable and a curable condition. A high degree of suspicion from your side would go a long way in taking care of the patient. Thank you.